Hello and welcome back to the Neurotransmitters. I'm your host, Dr. Michael Kentris, and I am joined again today by my co-host, Dr. Galina Geichman. Galina, how are you doing today?
I'm well, Michael. I'm so excited to be back and looking forward to another episode.
Yes. So, not to give away the topic too quickly, but when people are listening to podcasts, say on their morning walk or when they're getting ready and moving around, this might be the perfect topic for them, would you say?
Yeah, you pick up the podcast and you just walk into this topic.
Yes. So we are joined by a very special co-host also. So Galina, would you go ahead and introduce them?
Of course, and I love what you've been saying, Michael, about, this is really friends of the podcast and friends of ours. And Maeve O'Hare is no exception to that. She is one of our expert neuromuscular specialists here at the Brigham and Women's Hospital in the Mass General Brigham system and one of the core faculty in neurology at Harvard Medical School. And she's 100% the first person I call when I need help with a neuromuscular patient or when I need to interpret those really thoughtful and detailed EMG reports that she sends to me. I'll reply back and say, wait, so what's actually going on here? And she'll give you the lowdown. But thank you so much, Maeve, for being here and welcome.
Well, thanks for having me.
Maeve also led a wonderful session at the National Neurology Conference on an approach to the undifferentiated gait disorder. And it was in seeing this presentation that I really thought she'd be the perfect speaker for this topic to really help us, Michael and our listeners to, as you like to say, walk through the approach to what's going on with difficulty walking.
This subject today is rife with puns, so I hope our listeners will forgive us.
So I guess we could just get started with actually the question I wanted to start with, May, was what are the ways in which either patients are referred for this problem or that they talk about, the difficulty with walking? I mean, I think I've heard lots of different things from patients. They don't necessarily say, I have trouble walking. They might say something else. But what are the types of reasons that a patient might come to see you or to see their primary care provider before they're referred into us?
Yeah, so I think gait disorders can present. Well, first of all, this is probably one of the broadest topics in neurology, right? Because it encompasses so much. But because gait is such a complex, phenomenon that requires integration of so many different aspects of the nervous system. But broadly speaking, I think patients might present very simply complaining of something's altered with their gait or they're not walking right. They often might use the term imbalance, feeling off balance. They might be falling, having issues with tripping, stumbling, falling. I think one of the really tricky parts is sometimes they might come to my clinic with a diagnosis that might not be accurate. So, for example, they might get referred with neuropathy, which is pretty specific diagnosis. But what the patient really is trying to convey is that the sensation is altered in their feet and they feel like their balance is affected as a result. And so sometimes I try to take a step back and just fundamentally think, well, the problem is that they can't walk. Let's keep an open mind and take it from there.
Yeah, I always find that's one of the hardest things is if someone does have a diagnosis when they get sent to you, it's very tempting to anchor onto that and not kind of do your own evaluation. And that's, I think, an easy trap, especially if they've been seen by another neurologist. I know we're talking more about the primary care setting, but sometimes if it's another neurologist, we're like, well, they must have done a good job, right?
Right.
Maybe you have some disagreements with the assessment, so that can certainly happen.
Yeah, this is kind of why Galina was mentioning we did this course at AAM this year, which was myself, a neuro PT, and a movement neurologist coming together to give this talk together because we realized we all see these patients in different contexts and they get different and with different referral patterns. And it can be really tricky when patients get sent down the wrong pathway. So someone gets flagged as Parkinson's disease, but truly they have lumbar spinal stenosis. And just trying to think outside the box and take it back to basics, even for neurologists, is really important.
One of the things, kind of starting from a fundamental perspective, I have a little bit of a different training background. I'm a DO graduate, and so we had a lot of musculoskeletal type of stuff in our medical school, which I know is slightly atypical. I mean, there's some stuff that's maybe a little voodoo-y. But as far as like gait analysis, I always think that that's something that gets underemphasized in a lot of medical school training. I mean, one of the things that kind of really stuck with me is that, walking is basically a series of controlled falls. And if anything in that cycle, that gait cycle goes off balance, it can obviously result in instability, falls, wobbliness, however the patient characterizes it. So, as you said, we have different referral patterns depending on if we're in a subspecialty practice or a general practice. But what do you think is usually the best place to start when you're getting these patients at your door?
I think so. The helpful part is that in our clinics, we walk out to get our patients. So we literally are observing their gait from the very beginning, from the first moment that we meet them. And that is like my number one opportunity to see, are they, is there a clear pattern here? Is the, just like taking in as much as you can as that short walk, as we could take that short walk down the hallway. Are they using any aids? Do they need support? And using that as like the basics of like how I'm going to start talking to them about it. But a lot of it comes down to just observations with the exam that will help put you on the right pathway.
I think you made such a key point, Michael, about gait analysis, because that really actually takes in the context that the gait may actually be different from like the subsidiary elements of the neurological exam. And that's something that I've always found interesting, that I try to kind of think of that as a different part of the exam than testing strength, testing sensory change. I guess we're jumping a little ahead to the exam, and we could always go back to the history, but for that aspect, Maeve, can you talk to us a little bit about gait analysis, kind of broadly defined, like what are the components and how is that different from the initial, let's say, like phase dependent elements of the physical exam?
Yeah, exactly. So I think what you're kind of separating out is that we have our like neuro exam, which includes, motor, sensory, reflex, and all of those things are really key to getting an answer with a gait disorder. But then the integration of all of that plus very higher cortical functions all comes together with gait, the gait cycle, which, we're all used to looking at what normal gait looks like. And I think something I learned a lot from the neuro PT that I worked with on the course that we did was just how to describe the components of the gait cycle. So there's, and we don't need to get like too into the weeds here because you can really, really get very detailed with like various subcomponents of gait. But there's, phases where the foot is in contact with the ground, the stance, and then there's phases where the legs are swinging, and that's the swing phase. But normally there's, and there's elements of rhythm and cadence and speed and kind of symmetry. And those are all things that you may not be thinking about explicitly when you're looking at someone walk, but they do flag as abnormal when there's an abnormality. And so it's just a question of sometimes really paying attention and seeing, like which leg appears to be abnormal. What leg is the person favoring? What are they spending more time standing on one leg? Is there a problem with the movement of the leg when they're swinging it? The other side of things. Sorry, I'm not explaining that very well, but it's easier with videos. I think videos are really key here because, and I use that a lot in my clinic where I'll video someone's gait and then I can really slow it down and watch it on repeat so that I can really flag, oh, it actually looks like the problem is the left leg is a little bit stiff, or it's the right toes are not clearing the ground properly. And you can pick up those observations when you see the same cycle a couple of times.
Yeah, I think that was one of the things that I learned from the course and from talking with you, was the actual idea that when you look at it all together, it's hard to differentiate so much information. And I think it taught me that you can just stare at the right leg for a bit and then watch that cycle, and then just stare at the left leg for a bit, and even just stare at a component of the cycle. And for me, it's actually making the note of, even if there's consistency cycle to cycle, right? Because sometimes I think about it's not the only case, but something like a functional neurological disorder, like that gait will look different, potentially inconsistent. Again, I'm oversimplifying. That's not the only marker of it, but, seeing how those cycles change over time. And I can't emphasize enough the video point is it's kind of like the advice I've been given by neuro-ophthalmologists about eye movements. It's just like, you're not going to get it the first time. Just you're mostly focusing on examining them the right way as you video it.
I think those are all great points. And I think one of them, to your point, with doing this course with a neuro-PT, one of the most valuable experiences I had as a medical student was spending a few weeks with physical therapists on a rehab rotation. And literally all we were doing was like walking patients. I shouldn't say all, but a large proportion of it was just that. Yeah, I kind of felt the same way when I was first learning about, how to describe different kinds of movement disorders as a resident, where it's like you can see that something's kind of off, but you don't know the words to describe it properly. So a lot of it is kind of getting your mind to recognize what your eyes are seeing and putting that into a framework that makes sense from a kind of medical context.
And I'll also just say, I think it's much more helpful to use these broad descriptive terms than to try to snap someone into a bucket immediately. The gait analysis gets pretty skimmed over in med school, right? So you end up with these sort of buckets that have abnormal gaits, like a Parkinsonian gait is shuffling, stooped, or multiple other adjectives you could apply. Sometimes patients get snapped into that category too quickly because there might be some shuffling characteristics to their gait, but maybe that's not all of it. And a lot of things can make you shuffle, right? And so just trying to keep things broad and a little bit agnostic of the diagnosis when you're describing what you're seeing is, I think, really helpful.
Going back a little bit to what I mentioned about history, can you tell us, Maeve, are there particular ways that patients will describe in their own words, their own chief concern, their difficulty with unsteadiness or with gait that clue you in potentially to one diagnosis versus another?
That's a great question. I mean, honestly, you could talk about this all day, but I think one of the big differences that people describe is feeling that the problem is kind of up in their head versus down in their legs. So sometimes people who have maybe, say, balance disorders that are related to things like polypharmacy, or, any kind of centrally acting meds, maybe some ataxia from cerebellar problems, or even maybe kind of a hypoperfusion problem from orthostatic hypotension, they'll often kind of be gesturing to their heads and be like, I feel off balance. Whereas someone who's got a problem with kind of sensory motor function in their legs will really locate it there. So that can be just a good place to start. And then I think identifying whether there truly are problems with sensory and motor function will really take you down a different pathway very early on, compared to if someone's really just complaining of pain or stiffness or other things that are maybe there's a differential beyond the nervous system.
I think that's a great point. We tend to think as specialists about neurologic causes of gait problems, but there are many other causes that are kind of obliquely or perhaps not related at all. And a lot of times those are going to be hitting their primary care doctor before they get to us, and possibly even fixed before they come to us. But what would be some of the more common things that people should look out for as far as the non-neurologic causes?
Yeah, I think, osteoarthritis is probably the biggest thing, involving the knees, the hips. And this can sometimes get, maybe mislabeled as neurologic because patients are complaining of gait disorder or slowness or stiffness. But ultimately, it's a joint problem. And then there can be some kind of deconditioning that goes along with that. So in patients who have really bad hip disease, they'll get weakness of their hip abductors as well. And that can create an abnormal gait pattern where you get this swaying from side to side, the classic Trendelenburg gait. And so I see that in clinic as well. That gets labeled as, proximal weakness, maybe, where in reality, the problem is primarily that they have intensely degenerated hips. Yeah.
Maeve, are there particular go-to questions that you just love to ask on history? Because these are challenging histories to obtain. It's kind of like, a headache history where you really have to like tease it out and be like the number, and really they may be denying kind of or minimizing the amount. So do you have teasing questions for gait difficulties that sometimes end up being high yield?
That's a great question. I think one thing, as neurologists, we're usually obsessed with is the tempo and the time course. And like, when did you first notice it? When were you walking normally? When did this begin? And like really asking like in a million different ways, what were the beginnings, the origins, the evolution of this? Because that will, beyond localization, that will really help you clear yourself into the diagnosis, and also kind of the acuity and the how urgent this referral might be. I think falls are very important to ask about, and I usually try to ask about the most recent fall if someone's falling frequently, so that I can really understand what happened, what was the context of one fall, rather than saying generally when you fall, what happens. It's helpful to say, what was the last fall? What were you doing? Like, had you just stood up? What was the environment? And getting like as much detail as you can about one fall. That's sometimes high yield. And then some sort of questions are just sort of, like I said, like any disorder of sensory function, motor function, the presence or absence of pain. Those things are all really important to find out about as well.
Something I found, and I'm curious about your experience, is that I'll ask, because a lot of these patients are going to be on the older side of things, and there's a bit of pride sometimes associated with not being able to walk properly. And so I find that a lot of, again, here in the Midwest at least, a lot of people tend to minimize their symptoms. And so if I ask about falls, they'll say, no, I haven't fallen. And then I'll ask, like, well, have you almost fallen? And you find out, like, yes, they caught themselves on the sofa or on the wall, and like they would have gone down if they'd been in a larger space. And it was just luck that they haven't fallen so far. Or, their spouse will throw them under the bus and say, like, it's like, I caught you. You would have fallen if I hadn't been there.
Exactly, yeah.
Something else you mentioned that I thought was interesting, and I find it's a useful thing to differentiate out, is the pain as well. And obviously there's a lot of different kinds of pain, but what are the characteristics of pain that make you think of more of a neurologic issue versus, say, like a musculoskeletal or spinal type of issue?
Yeah, great question. So I think, the kind of neurologic causes of pain that would affect gait, what I'm really thinking of are problems with the peripheral nerves or problems with nerve roots. So peripheral neuropathy can be extremely painful, and patients will often use terms like, burning pain or kind of hypersensitivity, or they'll have like bizarre phenomena because they've lost sensation in their feet. They almost like have these sensory hallucinations where they're like, no matter what I do, it feels like my sock is bunched up in my shoe, or I got rocks in my shoe, got sand in my shoe, like my feet feel wet. These kind of like weird sensory phenomena often go along with kind of neuropathic pain symptoms. And so usually kind of the distribution of that is fairly obvious because most forms of peripheral neuropathy begin in the feet. And so it'll be this kind of symmetric presentation in the feet. And then the disorders of nerve roots, or, any kind of problem with the kind of particularly the lumbosacral nerve roots, which, L5S1 are the nerve roots that really control a lot of the sensation and motor function of the feet and are important for gait. Disorders of nerve roots are really painful as well. And that pain usually feels different in that it has this radiating quality. So we generally refer to that as radicular pain, or sometimes the term sciatica is used. But a pain that feels like it's originating kind of in the back or in the buttock and radiating into the leg or into the thigh or even all the way down the leg. That's very suggestive of a nerve root problem. The other thing that's very suggestive of nerve root kind of impingement to me is a very positional nature of pain. So it's pain that's worse if someone's lying down or standing up, or they have certain positional triggers for it, or the classic neurogenic claudication, where the pain is provoked by walking a certain distance and then alleviated by leaning forward or, just sitting down and having a rest. So those are all the things that would make me think about either neuropathy on one hand or radiculopathy on the other. And I will say, patients who are experiencing these kind of painful sensory phenomena usually just use the term neuropathy. They might not relate things to their kind of lumbosacral spine nerve root region. So that's why when someone comes into my clinic complaining of neuropathy, I'm always trying to keep an open mind as to what the actual etiology is.
Those are all great points. One thing and again, I'm just curious for your anecdotal opinion, that neuropathy obviously is one of our more common diagnoses that we see in the neurology clinic. And we're talking about people who are having trouble walking. At what point do most neuropathies, if we're saying like our traditional, small fiber diabetic type neuropathy, how severe does that have to be before we start seeing that affecting gait for most people?
This is a really good question. And I think it's actually something that's come up in clinical practice quite a bit, because especially in a context where you have maybe competing diagnoses and you're trying to figure out, well, what's really affecting the gait? And someone has this sort of mild diabetic neuropathy. I think it's fair to question, is this really affecting the gait? I think the times when peripheral neuropathy really definitely affects the gait is where there's a loss of proprioception. So a problem with joint position sense manifesting as not knowing where your feet are in space, that can clearly affect your gait. And so that's one piece. And then the other is weakness. If someone has really advanced peripheral neuropathy to the point that it's causing them to have weakness of their ankle dorsiflexion, that's going to impact gait as well. But a pure small fiber type neuropathy where you might just have pain, kind of hypersensitivity, altered pinprick and temperature sensation, that wouldn't really affect gait in a major way other than making it painful to walk, but it shouldn't affect the mechanics of gait. So yeah, I think it's a great point.
Yeah, because I find that's exactly what I wind up with is I have someone in their, 70s. They've got spinal stenosis, prior L5S1, laminectomy infusion, mild diabetic neuropathy. It's and now they're having, some balance traumas. Well, it's probably all of these.
All of the above.
Right.
Exactly. Yeah.
Maeve, I know that we're all neurologists on the call here, but thinking of our non-neurology friends who might be listening, can you walk through the exam in a little bit more detail and just share your kind of best approach to strength testing in these patients and actually sensory testing? How do you sense vibration or proprioception, and kind of contrasting that with the small fiber testing, just to review those elements, and then we can get to maybe any bonus maneuvers for gait.
Okay, perfect. Okay, so we already talked about sort of the gait cycle and analyzing that and observing that. And then when you get the patient sort of sitting or lying down in your office to do the more detailed neuro exam, I think I usually start out with sort of moving the arms and legs around to feel tone. Is there kind of a spasticity or tightness to the tone, or rigidity that might suggest something like Parkinson's disease if they're really rigid and stiff throughout? And then I test strength. So for strength testing, this is sort of something that I think we as neurologists get more and more comfortable with knowing what normal strength is because we do it so many times a day. But it's important to disambiguate someone who's limited due to pain versus someone who's truly weak. They're not giving you any resistance to the movement because they can't. So I'll often be questioning patients during it, like, is that, if someone is having a hard time flexing their hips up, I'm like, is that painful for you? Or they're just, or is it truly like a weakness, like you're not able to make the movement? And I test like each muscle group individually. And then I'll, for the sensory exam, I think the sensory exam is sort of like off-putting maybe for many non-neurologists because there's so many components to it. And, you want to make it a useful exercise and not kind of a waste of time. And so I think it's good to think about small fiber modalities of sensory function, so pinprick or temperature, and then large fiber, so joint position sense and vibration sense, and maybe pick one of each and just check that. So you could use a tiny pin, and I'll pick an area that I know sensation is normal for. So I'll just show them what a pin feels like on their forehead. And then I'll just say, okay, this is 100%. You feel that sharp sensation. We're going to call that 100% sharp. And then I'll move to the foot and say, does it feel 100%? It's either yes or no. I think you can get really into the weeds with, can you do it again? 99%, or, maybe, especially if you're like check an area that's like a slightly calloused, and then so I'm really just trying to get a very broad sense of like, is there a problem with that modality of sensation? And then I'll move on to check some large fiber function. So especially for gait, we're particularly interested in problems with joint position sense. So holding the toe on its sides, not on the top and bottom, because that's giving them way too much extra information to work with, but holding it on its sides. And then just moving it, very, very small movements, and telling someone before you start, this is up, this is down. Can you tell the difference? And then having them close their eyes and say, now where is it? Now. And then have them, you do it at least 5 times to get a sense of whether they're guessing or not. And then the other great test for proprioception is the Romberg test, where we have patients stand up, feet together, look straight ahead, and see, are they able to keep their balance in that position? And then have them close their eyes and see if they start to sway, which indicates that once you've removed the visual inputs, they're really struggling to maintain balance from proprioception alone.
I find that the Romberg is one of the more misunderstood tests.
Yeah.
So I see a lot of places teach it with like the arms outstretched, like you're doing pronator drift simultaneously. And I always have to tell people, like, no, we don't need to do that at the same time. Mm-hmm. So I'm just curious, when do you consider a Romberg to be positive? And do you have gradations of positivity? Like I've seen people write, with sway, or positive, or just absent, or negative, What are your thoughts on the Romberg assessment?
Oh yeah. I mean, it is hard because, there's so I'll say, to start out with, if someone can't just stand upright with their feet together and look straight ahead with their eyes open and keep their balance, then you can't really proceed with the Romberg, because there's probably something else that's affecting their balance, and we're not going to be able to remove other sensory inputs and figure out, is this truly a proprioceptive problem? But if someone is like good with that part and they're standing up and they look great, eyes open, feet together, then you get them to close their eyes and they start swaying. I think you're absolutely right. There's like a range of how much someone can sway. Some people, they're going to go way over, and it's kind of scary to watch. Try not to let it get that far. Like, I don't want someone to fall on me. But if someone's swaying slightly, usually I'll give them, a minute in that position, or 30 seconds, to see if they kind of right themselves. Because everyone feels a little bit off when they first start doing it. And people will often start saying, oh, I feel off balance. I'm swaying, aren't I? Because they're nervous because they're seeing a neurologist for the first time, and they're like, they're stressed about how their performance is looking. And so I'm like, no, you look good, and try to reassure them and see if I can settle them into it. And then if they stop swaying and sort of, steady themselves, then I call that a negative Romberg.
Okay.
And then
I'm not doing my Rombergs long enough then.
Well, yeah, I think you're supposed to do it for quite a while. I know, yeah, we don't have enough time. But the other thing that you can do that I read about in one of myself and Galina's mentors, Marty Samuel's textbooks, he does a stressed Romberg, or he did this kind of stressed form of the Romberg, where if you think about the components of the sensory system that are contributing to balance, we have, the visual input, so like seeing where you are in space, proprioception, which is what we're really interested in, kind of a sensory function perspective, where you can feel where your feet are in space. And then there's this whole complicated vestibular system where your ears are telling, your inner ear is giving you a lot of information about where you are in space. So the point of the Romberg is we remove the visual input. We're left with just vestibular and proprioception. And if there's a problem with proprioception, you'll start to sway. And what Marty did was stress the vestibular system as well during the Romberg. So make it more complicated for the patient by having them shake their head side to side with their eyes closed. And then sometimes you'll bring out a proprioceptive problem more so because you're sort of downgrading another sensory element that's contributing to balance.
Maeve, I didn't know that, but I'm so glad you mentioned Marty Samuels, because he used to tell the stories of how patients will tell you on their history, if you're really listening, that they've had a positive Romberg. And often it's that when they close their eyes in the shower, that's when things get really off. And so I always kind of joke that, a la Samuels, the shower is the Romberg machine. Yeah. Where the patient will say, I can't take showers anymore, or I've changed how I do it, or I'm sitting, or I'm holding on. And I have to say, I heard another very interesting patient experience portrayal of the Romberg, which is a gentleman I saw who said to me that he doesn't fall, he doesn't sway, everything's okay, except in church when they stand up to pray and at the end the priest asks them to close their eyes and raise their hands to the ceiling, he consistently falls now.
No.
This is a very, very distressing experience, but I looked at him and I said, thank you, sir. You've given me another story to add to the kind of functional Romberg testing out in the real world.
Exactly. Yeah. I mean, the other thing as well is like just lighting. So like if someone's just walking in dim lighting, this is why, there's probably a lot of reasons why people fall in the middle of the night, but that's one of the big ones, is that you're removing the visual aids that help people maintain their balance. And so any kind of sensory problems come to the fore.
So Maeve, you're a neuromuscular specialist. So is the answer just EMG for everyone?
I would say no. I think so when is an EMG helpful? I think an EMG can help with identifying problems with the peripheral nervous system that might be contributing to gait disorder. But certainly I don't think it's helpful in every single patient. Like Michael was mentioning, someone with sort of like a mild small fiber predominant diabetic neuropathy. And by small fiber predominant, I mean really it's just like they have pain and sensitivity, but their motor and sensory function is otherwise pretty good. First of all, we might not pick much up on an EMG. And second of all, even if we do show some mild neuropathy, like, is that really the cause of their gait disorder? So I would caveat the EMG with that. But if someone has clear-cut sensory or motor problems with their, legs, and you really think this is what's contributing to their gait disorder, an EMG is probably going to be pretty helpful in, number one, defining, is this a peripheral neuropathy, or is it alternatively, as I mentioned, like, could it be a problem with the nerve roots? And what's the severity, and what's the characteristics? Is this like a axonal or demyelinating, which helps us in neurology clinic because we have a totally different differential for both of those subtypes of neuropathy? Or is the EMG totally normal? And then you have to think beyond the peripheral nervous system. Could it be a spinal cord problem? So I think EMG is really helpful in those situations. So I would say any identifiable sensory motor deficits that you think are contributing to the gait disorder, EMG could really help figure that part out.
And I assume if we're thinking like nerve roots or spinal issues, we're looking at some imaging as well in those select cases.
Yeah, exactly. Yeah. So if we got that history that I described earlier where someone is having, that kind of radiating, shooting pain, or that classic neurogenic claudication where they can only walk so far before they have to stop and rest or change posture, then I would image their lumbar spine.
And I know, I think we're all practicing here in the US. And so insurance for a lot of people getting MRIs, especially of the lumbar spine, can be challenging. And so if they haven't, I usually find that if they don't have documented like a focal weakness or some sort of, as you said, some sort of physical impairment, then getting it approved without a preceding course of physical therapy for X number of weeks is nigh impossible.
Yeah, that's it. That's a good point. I have to say I haven't run into that problem a ton, but it's possibly just the selection bias that, like whoever I'm seeing in my clinic, they've already kind of gone down those pathways. But I think that's actually reasonable though as well, right? Because a lot of radiculopathy symptoms do get better with physical therapy and conservative measures, and really, maybe a significant proportion of these patients don't require imaging if they have less than 6 weeks of symptoms, and there's, as you said, if there's no like sensory or motor deficit on their physical exam.
Yeah. I know I've had a couple older gentlemen that I go to church with who have come up to me and asked me like, Mike, I'm having trouble with this back pain. And I was like, well, how long has this been there? It sounds like your classic kind of L5S1 sciatica kind of picture. And I'm like, well, it's only been a few weeks, do the physical therapy. And, they're like, they're out there talking to spine surgeons. And I'm just like, whoa, whoa, whoa.
Yeah, exactly.
Pump the brakes
That's the
a little
last
bit.
thing you want. Yeah.
And, most of them, they both got markedly better. I mean, did it go away entirely? No. But are they thinking about spine surgery anymore? Also, no. Which kind of brings me to a second line question. So let's say we've got this person with an undifferentiated gait disorder. They've only seen their family doc yet. They're like, maybe it's a little bit of this, a little bit of that. Is there any situation where physical therapy is the wrong choice?
Yeah, that's a great question. I actually think a lot of patients ask me that question because they're worried. They're like, I wanted to see you first.
Right.
And to give me the all clear. There's really nothing I can think of that PT is going to worsen. People are worried about neuropathy worsening with physical therapy, which, like mechanistically, that just doesn't really make sense and it wouldn't be a concern. So yeah, I usually say just, within reason, obviously you're not trying to like, put yourself in a ton of pain by pushing through a bunch of exercises, but within reason, staying active, mobile, and like engaging with physical therapy is usually the right move regardless of the diagnosis.
I would say a lot of physical therapists know more about gait than a lot of physicians do, unless you spend a lot of time specifically studying it. It's just not something part of like standard medical curriculums, like we were saying earlier.
Yeah, especially like any PT with kind of neurospecific experience, they're going to be the expert on gait analysis, and they're going to help. They're going to be diagnostically helpful as well as therapeutically helpful, because they can help figure out, is a problem to do with sensory function, motor function, tone, or is this more orthopedic? They'll actually, often if you have a conversation, they'll be really helpful.
Also found, to your point, Maeve, about them being both diagnostic and therapeutic, is like physical therapies who I really rely on when I think about augmenting the quality of life for the patient, because sometimes you go through this diagnostic process and, we give ourselves a pat on the back. Okay, great. Sensory, ataxia related to large fiber neuropathy, boom, done, right? And we have the diagnosis, but then the question becomes, how do we manage it? And if there's a pain component, maybe we start to take on a little bit of the pain management for the neuropathic component. But in addition, I will often talk to patients. I'll have the walker talk, as I call it, which is sort of discussing, what would be the utility of an assistive device and could it be helpful? And I personally don't, fit patients for that, but I rely on my physical therapy colleagues to think about whether, assistive device is broadly defined. But can you give us just a quick comment on what those might be, or perhaps how you talk to patients about them to try to persuade them that it could actually be helpful for maintaining their independence?
Yeah, I probably similar to you in that I really rely on physical therapy to make the assessment of like the safety with a device, because some patients, a walker is not the right move, and it might even increase their fall risk, depending on different factors. So I usually try to have a conversation with the PT that the patient is working with and say, like, do you think like a cane or a walker would be helpful here or not? Do you think this is something that's remediable with strengthening or balance training? I think I'm maybe more prescriptive when it comes to like very focal motor deficits. Like someone has like a foot drop and they're clearly just catching their toes and they're tripping and falling as a result. Then I talk to the patient about using, an assistive device like an ankle foot orthotic, an AFO, to keep the foot raised. And that patients often are really, really hesitant about pursuing an AFO because it comes with a lot of kind of connotations, negative connotations of disability. But I try to, emphasize that this is like a safety measure. It's really going to help maintain your independence and ability to get around without putting you at an increased fall risk, or at least reducing your fall risk. And so, yeah.
Those are all great points. Any other things that you say? I mean, obviously, a lot of these treatments and further diagnostic investigations are going to be very dependent on what your initial assessment shows, and there's a lot of different rabbit trails to go down. But what's the one thing that you see missing most often in the assessments or thought processes that you wish people would catch on?
I think I'm always very appreciative when someone has come to my clinic and they've tried some physical therapy. And then I am appreciative, but I understand the limitations when someone has been recognized as having, sensory motor problems and had kind of some initial workup for that with like an EMG and some imaging of the, lumbar spine or higher in the spine as appropriate, depending on the pattern of symptoms. So I find that really helpful. But I think that's tough maybe for a generalist to achieve in every patient, especially because the other point that we're trying to make with this whole conversation is it's important to keep an open mind as to the differential diagnosis and think about orthopedic and non-neurologic and kind of medication-related causes of gait disorders, as well as the more clear-cut diagnoses that we've discussed.
I think one thing I'll add sorry to jump in, is just around neuropathic pain management, because I think it's super helpful if someone has tried something, if the nature and characteristics of the pain fit a neuropathic picture, and one, they haven't been, suffering for many months waiting for you. They've been on maybe a dose of something or maybe a lower dose of something. And then you can feel both you have a little bit of therapeutic information. How did they do with it? It helps you even potentially diagnostically, did their pain respond to a neuropathic agent, but also gives you something that you can do in terms of increasing the dose or trying alternatives. But I find that sometimes on history, almost their response to some of these medications can be helpful into cluing me into what's going on.
Yeah. And I'll just say one additional piece to that, just to push back slightly, is just sometimes there's a little bit confusion about what neuropathic pain medications can achieve. So patients, sometimes I prescribe them just for numbness and tingling, when it's, things like gabapentin help with neuropathic pain and they reduce the intensity of pain in not all patients, unfortunately, but they do not help with the loss of sensation or that kind of altered sensation. And so they're only going to have side effects in that scenario. So just to make sure that we're treating with neuropathic pain meds, we're always treating pain and not just kind of non-specific sensory symptoms.
That's a great point.
Yeah, great point about expectation setting too in education. Well, Maeve, it's been so wonderful to have you on the show, just sharing your wisdom, walking the talk, as they say, walking the talk. Yeah. And I feel like I could learn so much more from you, and hopefully we'll be able to chat more about this another time. But any final words, anything else to share?
Gosh, I can't think of anything snappy to say. I was thinking I've run out of puns. But well, thanks for having me. This has been great.
Any projects that you'd like to plug or anything you're working on presently?
Well, we're doing kind of a streamlined version of this talk at the fall AAN conference, of the kind of gait disorder talk that I mentioned earlier. That's what I'm working on right now. But
it's a
awesome.
Can't
so
miss.
If you want more, yeah, catch Maeve in November.
Awesome.
All right.
Galina, any final words today before we all sign off?
No, just thank you again, Michael. Thank you again, Maeve. Thanks to everyone for listening. And if we are addressing chief concerns that you like, let us know. And if we're missing chief concerns you want to hear more about, let us know as well.
Find all of our prior podcasts on your favorite podcast app, and you can always check out our website at theneurotransmitters.com. Thank you all for listening again, and we'll talk to you again really soon.
Thank you.